Good morning to my respected teachers, my seniors, my colleagues of Department of Physiology, BURDWAN Medical College. I, Dr. SHOUVIK Das, first year PGT Department of Physiology, going to discuss jugular venous pressure, cardiac cycle and heart sound. Initially, we going to first discuss regarding jugular venous pressure. We know that jugular venous pressure, it is a oscillating top of the distended proximal portion of the internal jugular vein, represents volumetric changes that reflect the pressure change in the right side of the heart. It is very useful for differentiation from different types of heart and lung disease. Classically, there are 3 upward deflection and 2 downward deflection. Upward deflection are A waves, C wave and V waves, and downward deflection are X wave and Y waves. Now, from the knowledge from anatomy, we know that jugular vein are 2 types. One is internal jugular vein, another is external jugular vein. This is the schematic diagram of internal jugular vein, external jugular vein and internal jugular vein. Internal jugular vein, it lies lateral to the carotid artery and deep to the sternocleidomastoid muscle, and external jugular is superficial to sternocleidomastoid. Then examination. Usually it is bedside examination to assess CVP, central venous pressure and waveform. Right interjugular vein is used for estimation of venous pressure along with its waveform. Unlike external jugular vein pulsation, it is not possible to see internal jugular vein pulsation directly, as it is lies deep within the neck and covered by sternocleidomastoid. Actually, we see that transmitted pulsation overlying skin and soft tissue. Internal jugular vein is preferred to assess JVP due to anatomical plus point. Number 1, it have direct course or straight line course to superior vena cava and right atrium, and more accurately reflect the dynamics of the right heart. Transmission of right atrium pulsation prevented by prominent valves at the proximal external jugular vein. The structure of neck, upper thorax causes extrinsic compression of external jugular vein. So, in case of congestive cardiac failure, there is increased sympathetic activity causing vasoconstriction of external jugular vein. So, pulsation are barely visible. Then question is, why right side is preferred over left side? Because right side internal jugular vein have a straight line course and it is less likely to extrinsic compression from other structure of neck muscles. Multiphasic JVP beats two times in a cardiac cycle, whereas carotid artery beats one time in a cardiac cycle. So, there are two waves in the JVP for each contraction and relaxation cycle of the heart. And first beat represents atrial contraction termed as A waves, and second beat represents venous filling of the right atrium against a closed tricuspid valves termed as V. Then measurements. There is sternal angle or angle of Lewis. It used as a reference point. Anatomically, it is found that approximately 5 cm above the center of the right atrium, there is a position of sternal angle. So, this is the fixed relationship between sternal angle and right atrium. Then, level of sternal angle is about 5 cm above the level of mid-atrial, mid-right atrium in any position. Examined in any position in which top of the column is easily visible. Normal subject is less than 30 degree in position. Most patient with heart disease is 45 degree position. In patient with high venous pressure or a greater inclination is required to obtain visible venous pulsation. Usually, JVP is less than 8 cm of water and less than 3 cm column above level of sternal angle. Then visualization. Patient should lie comfortably. Trunk is inclined by an angle. Elevate chin and slightly rotate head to the left. Neck and trunk should be in the same line. When neck muscles are relaxed, shine a beam of light tangentially across the skin, overlying the internal jugular vein to see its pulsation. Simultaneously, pulsation of the left carotid artery or carotid auscultation aids in timing of JVP in cardiac cycle. Then this is right atrium. Above 5 cm there is the angle of Lewis, and this vertical angle above the Lewis is 2 cm. This is the top of jugular vein. So JVP is 2 from here and 5 cm from here. So total 7 cm of water. This is the position of 45 degree position, and this is the internal jugular vein, and pressure is estimated. Then measurements. It measured by two scale method. Normally, jugular vein pressure does not exceed 3 to 4 cm above the sternal angle. Since right atrium is approximately 5 cm below the sternal angle, the jugular venous pressure corresponds to 9 cm, that is 7 mm of mercury. Elevated JVP more than 4 cm above the sternal angle. This is the measurement of venous jugular pressure at bedside. This is the JVP waveform. JVP has a biphasic waveform. And correspond to the A wave, the fast positive presystolic waves. Right atrial contraction. It precedes the upstroke of carotid pulse synchronously with S1, followed P waves of ECG. Peak of the A waves demarcates the end of atrial systole. Dominate waves in JVP during inspiration and larger than V waves. This is A wave. And this corresponds to S1 wave. Then X descent. X descent is called systolic collapse, followed A wave. This is X descent. Correspond to atrial relaxation and rapid atrial filling due to low pressure. Most prominent motion of normal JVP begins during systole and ends just before S2. This ends just before S2 and larger than Y waves. These are larger than Y waves. Then X prime. X prime or X descent. This follows the C waves. Occurs as a result of right ventricular pulling the tricuspid valve downwards during ventricular systole. As stroke volume is ejected, the ventricle takes up less space in pericardium, allowing relaxed atrium to enlarge. Can be used as a measure of right ventricular contractility. C waves. C waves is a second positive venous wave. Right ventricular or volumetric contraction leads to tricuspid valve to bulge towards right atrium. Then V wave. V wave also third positive wave is a V wave. Begins in late systole and ends in early diastole. Correspond to venous filling when tricuspid valve is closed and venous pressure increase from venous return. Occurs during and following the carotid pulsation and peak after S2. This is the S2. These are the peak. Peak after S2. Then Y descent. Y descent, it is a down slope of V waves. It is a down slope of V waves. And decline in right atrial pressure. Rapid emptying of the right atrium into the right ventricle following the opening of tricuspid valve in early diastole. Then it is normal pattern of jugular venous pulse. A waves, C waves, positive waves, X negative waves, V then positive wave, then Y then negative waves. This is regarding JVP A wave, C waves, X, V, Y, then A. These correspond to diastole, ventricular systole, and diastole. Then quantification. A classical method for quantification of JVP was described by Borst and Mulsusen in 1952. It has since been modified in various ways. A venous arch may be used to measure JVP more accurately. Moodle sign determine which waveform you are viewing. Feel the radial pulse while simultaneously watching the JVP. Waveform seen immediately after arterial pulsation is felt is the V wave of JVP. Then abnormality of the waves discussed. First, A wave abnormality. A waves or prominent or large wave is due to increased resistance to right atrium emptying, increased right atrium contraction. Example, right atrium myxoma, tricuspid atresia, and tricuspid stenosis. Increased right ventricular valves developments by RVH, right ventricular hypertrophy, decreased right ventricular compliance, that is seen in pulmonary stenosis, primary pulmonary arterial hypertension as in mitral stenosis, acute pulmonary embolism, right ventricular infarction. This is the graphical presentation regarding prominent A waves in tricuspid stenosis, in case of tricuspid stenosis. Then giant A waves or cannon waves. Right atrium contracts against closed tricuspid during right ventricular systole. Most prominent waves during arrhythmia is venous corrigan, regularly seen in form in junctional rhythm and ventricular tachycardia 1:1 retrograde conduction, and irregularly seen in congestive heart failure, classic atrial ventricular dissociation, ventricular tachycardia, ventricular premature contraction. This is the irregular cannon waves in complete AV block. Then absent A wave. Absent A wave seen when there is no effective atrial contraction, that is atrial fibrillation. Sinus tachycardia, A waves may fuse with preceding V waves. This is the absent A waves in case of atrial fibrillation. Abnormal X descent. Absent X descent, tricuspid regurgitation, blunting of X descent, early sign of tricuspid regurgitation, prominent X descent, vigorous right ventricular contraction, cardiac tamponades, constrictive pericarditis, and right ventricular overload seen in AST. This is a prominent X and Y descent seen in constrictive pericarditis. Then Abnormality of VOFs, prominent VOFs. Increased right atrial blood volume during ventricular systole when normally tricuspid valve is closed in tricuspid regurgitation. It can sometimes cause systolic movement of earlobes, right to left head throbbing with each ventricular systole, pistol shoot heard over internal jugular vein, and pulsatile ophthalmos. This is a prominent VOFs, with absent X descent but rapid Y descent in severe tricuspid regurgitation. Prominent VOFs in absence of tricuspid regurgitation, seen in large ASD, VSD of right of left ventricle to right atrium shunt, severe congestive heart failure, cor pulmonale atrial fibrillation. The VOFs become prominent in atrial fibrillation due to absence of AOFs. Then prominent A and VOFs. Non-restrictive ASD with normal venous pressure and CP, that means constrictive pericarditis with increased venous pressure. There is a prominent A and V with rapid X and Y descent in constrictive pericarditis. In case of ASD, prominent A and V. In non-restricted ASD. Then abnormality of Y descent. Rapid or diastolic collapse, Y descent. Elevated venous pressure, myocardial dysfunction or severe ventricular dilatation, severe tricuspid regurgitation and constrictive pericarditis. Frederick sign, constrictive pericarditis, usually accompanied by pericardial shock and severe right ventricular failure and ASD with mitral regurgitation. Slow Y descent, impeded right atrium emptying and right ventricular filling, seen in tricuspid stenosis, right atrium myxoma and cardiac tamponades. Slow Y descent with prominent A with slow Y. This is the slow Y. This is the slow Y descent. Then discuss regarding cardiac cycle. We know that from this topic we going to discuss regarding phases of cardiac cycle, events during cardiac cycle, duration of each phases and applied physiology. Then introduction. We know The heart is a pump. Two separate pumps in series. Systole responsible for contraction, diastole for relaxation. Cardiac cycle, both electrical and mechanical events from beginning of the one heartbeat to beginning of next. Then duration. If heart rate is 75 beats per minute, then duration is of one beat is 60 by 75, that is the 0.8 seconds. Then phases. There are two phases. One is atrial cycle and is a ventricular cycle. In case of atrial cycle, there is a systole 0.1 seconds, there is a diastole 0.7 seconds. In case of ventricular cycle, there is a ventricular systole 0.3 and ventricular diastole 0.5. Then atrial cycle. Atrial cycle, it is a 0.1. It coincides with the last rapid filling phase of ventricles. Before this, valves are open, ventricle relaxed with already 75% of blood. Contraction add only remaining 25% of blood. Then effect of atrial systole. Intra-atrial pressure, right side, 4 to 6 millimeter of mercury, in left 7 to 8 millimeter of mercury. Intraventricular pressure increased. Narrowing of origin of great veins and decreasing venous return. Then atrial diastole. It coincides with ventricular systole and most of the ventricular diastole. Atria relaxed. In case of gradual filling of atria, pressure slowly increases. In case of ventricular cycle, ventricular systole 0.3 seconds phases of isovolumetric contraction and phases of ventricular ejection. These are two phases. One is the rapid phase and another is the slow phase. Ventricular cycle. Phases of isovolumetric contraction is 0.05. When intraventricular pressure rises, closed AV valves, semilunar valves are not yet open, so contract as closed chamber. So no changes in volume, so called isovolumetric contraction. Sharp rise in intraventricular pressure. Then ventricular systole continuation. Phases of ventricular ejection is 0.25 seconds. Begins with opening of semilunar valves. Rapid phase is 0.1, that is 2/3 of stroke volume is ejected. The right ventricle's velocity is less than left, but duration is more. In case of the slow phase, duration is 0.15. 1/3 of the stroke volume is ejected. Ventricular diastole. Duration 0.5. This includes protodiastole, isovolumetric or isometric relaxation phase, rapid passive filling phase, reduced filling or diastole or diastosis, and last rapid filling phase. In case of protodiastole, that is 0.04 seconds. Ventricular systole ends, ventricular relaxation starts, interventricular pressure falls, blood comes back from vessels to ventricle, semilunar valves closed, so second heart sound is formed, and this causes dicrotic notch in the pulse. Isovolumetric or isometric, it lasts for 0.06 seconds, begins with closure of semilunar valves. AV valves are not yet open, relaxed as closed chamber, so volume remains same. So isovolumetric relaxation ends with opening of AV valves. Then rapid passive filling phase. As atrioventricular valves, AV valves open, atria till now in diastole, filled with venous return with increased pressure, causes rapid passive filling of ventricles. So, third heart sound is generated. Then reduced filling and diastosis. As ventricles filling continues, pressure difference reduces, so filling rate decreases. This is called diastasis. Diastasis. Total blood transferred with rapid and slow filling is 75% of total arterial blood. Then last rapid filling phase. It said earlier it coincides with atrial systole and add remaining 25% of blood of to the ventricle, and is with ventricular cycle completes. Then I am going to discuss regarding heart sounds. Heart sound is a sound produced from the heart. So it is the valvular events. First heart sound, second heart sound, third heart sound, and fourth heart sound. So total 4 type of heart sound is here. Then first heart sound. First heart sound causes closure of AV valve, characteristic by the lump, and the duration is 0.15 seconds, and the frequency is 25 to 45 Hz. Site of auscultation is a mitral and tricuspid area, and in case of the ECG correlation coincide with the peak of R waves. Then second heart sound causes closure of semilunar valves, characteristic by dump, duration 0.12 seconds, frequency 50 Hz. Site of auscultation aortic and pulmonary area, correlation with ECG coincide with the T waves. Third heart sound. Third heart sound is produced in rush of blood during rapid filling phase, characteristic of duration 0.1 second, and correlation with the ECG, it appears between T and P waves. Fourth heart sound causes last rapid filling phase, characteristic of 0.03 seconds, frequency 3 only, correlation with ECG, it appears between the P waves and an onset of Q waves. Then cardiac murmur. Abnormal heart sound during cardiac cycle is called cardiac murmur. Mechanism of production produced due to turbulent blood flow. Due to turbulent blood flow. Cardiac murmur causes, one is the valvular stenosis, valvular insufficiency, valvular septal defect, and coarctation of aorta. These are systolic murmur, maybe diastolic murmur, maybe continuous murmur. Then the duration of each phase. Duration, effect of heart rate. As heart rate increases, cardiac cycle duration decreases. If heart rate 200, cardiac cycle would be 0.37. So duration of each phases decreases, but diastole decrease is more than in systole. Then applied coronary blood flow to subendocardial area occurs during diastole. So diastole duration decrease, cardiac perfusion decrease. So ventricular filling also occurs during diastole, increase heart rate and decreasing cardiac output. This is thanks to all my teachers, again all my teachers and my seniors, juniors. Thanks for listening, and this slide ends with philosophical story. Life is like riding a bicycle. To stay balanced, you must keep it moving. Okay. Thank you very much. Thank for listening. Thank you.